Last week, we started with the head. We talked about the sensory structures mainly. This week, we're going to carry that on and kind of get into the rest of the head, move down into the neck, and then begin exploring some of the structures in the thoracic cavity. And then next week, we'll sort of follow that path and continue with the heart and cardiovascular system. So this week, we're speaking mainly about the neck, respiratory structures, and we're really going to start with an overview of the function of the respiratory system. As I mentioned before, it's nice to tie in the function. I won't typically test you on the function in the lab, but this will, of course, be applicable in your theory in the lecture part of the course as well. So the respiratory system, we know, is really important for exchange. It's going to help with oxygen supply to the rest of the body by picking that up through the lungs. And then it's also going to be getting rid of byproducts such as carbon dioxide. Those can be released through the lungs as well, and then eventually through the nasal and oral cavity. It's also going to help in terms of our sensory function, in terms of olfaction. So odors are brought in through the nasal cavity and then picked up by olfactory nerve endings. So it also helps in that way. And then lastly, the movement of air across the vocal folds. We'll talk about the vocal folds that are located in the larynx. Those are going to be important for producing sound, which is important for our voice and phonation. Now we can divide the respiratory system into two compartments. The airway, which is from the nasal cavity and oral cavity, both consist of airways, all the way down to the trachea, is really considered, not the trachea, excuse me, the lungs is really considered the conduction zone. This is mainly what we call that dead space zone because there isn't any exchange of oxygen or carbon dioxide happening. From the lungs, specifically the terminal bronchioles, and you'll talk about this in lecture, this is where we begin to see the respiratory bronchioles, where we have studying of alveoli. This is where we begin to see exchange, and so that can be considered the respiratory zone. So we can divide that into two parts, the conducting area where air is being passed versus the respiratory zone where transfer of gases is happening. Now, just to give a visual overview of the structures in this path, we start with the nasal cavity here. We spoke about this briefly last week, especially as it pertains to the nasal septum, dividing the parts of the nasal cavity. Then we have the oral cavity. We'll talk about the palate coming up. The palate helps to separate nasal cavity from oral cavity. Then we have the pharynx region, which leads into the larynx. The larynx is the opening into the trachea, basically the inlet. Then we have the trachea itself. And then we begin branching into the bronchial tree, which is several divisions of bronchi into bronchioles, and then we get to the distal most part, which are the alveoli, all right? And then if we kind of zoom in on an alveolus, here's what they look like, clusters of grapes, essentially, where gas exchange takes place. Let's also explore the salivary glands. So the salivary glands are found in and around the oral cavity. They're going to be important for producing saliva and secretions, and they're not to be confused with the tonsils. So there are also groups of tonsils. There are 4 tonsils that we'll speak about, and they're involved in the immune system, but the salivary glands are going to be more important for salivary production. They are the parotid gland, which is the largest of the 3, and they're all paired, by the way. So we've got the left parotid gland here. Here's this large glandular tissue. It's right anterior to the ear. We can also see the associated parotid duct. So this is how those salivary secretions actually enter the oral cavity. The second set of glands are the submandibular glands. So these are going to be inferior to the mandible. So it's just sort of tucked underneath the mandible here. There's the mandible that's cut for reference. And lastly, the sublingual glands are going to be beneath the tongue, right? Which is that third group right here. So these are the 3 paired salivary glands that are going to help release secretions into the oral cavity. And again, we can appreciate the small green structures being the relevant ducts for each of those glands. Let's move on to the lips. The lips and the, the frenula. The lips and the frenula basically anchor the outer aspects of the oral cavity. They also help to us with phonation in terms of pronouncing certain words. So pursing of the lips, as we know, is important for making certain sounds and also parts of chewing and speaking. The lips are going to help us with food intake, moving that food, controlling how that food is moved around or masticated in the oral cavity, certain aspects of articulation and phonation, as well as tactile, right? Tactile appreciation, especially for infants. That suckling reflex is brought about mainly by the lips. Lastly, it's going to be a part of our facial expression. So again, things like puckering the lips, pursing the lips, that kissing face that we sometimes make, or a more of an exaggerated or surprised face. All of these types of actions and expressions can be controlled with the lips. Now, the frenula are helping to anchor the lips to the inner parts of the oral cavity. All right, we've got the upper frenulum, which is anchoring the upper lip, the lower frenulum, which is anchoring the lower lip, and there is actually a third lingual frenulum, which anchors the tongue. So it basically helps with chewing and speaking as well by anchoring the mouth. Otherwise, if you were chewing and speaking, your lips and teeth would be moving all over along with the food. So really helping to anchor and stabilize the oral cavity. Moving on to the teeth, which are inside the oral cavity. These are going to be found located in the alveolar processes, otherwise known as the tooth sockets. And these are embedded in the maxilla and mandible bone. So the lower teeth are in the mandible. Here's the mandible. The upper teeth are in the maxilla, right? Now, there are different types of teeth. There are typically 32 teeth in total in a fully developed adult, but we have different groups of teeth that have different functions. So our incisors are going to be the front teeth. There are two types of incisors, the central and then the lateral. Then we have the canines, which are the sharp teeth really in the corners of the mouth, right? Here they are in the upper, and then here they are in the lower. Then we have the premolars. There are three groups of premolars, two groups of premolars, the first premolar, the second premolar, and then three groups of molars. So first molar, second molar, and third molar. So the molars are the ones that typically grow in a bit later in adult life. These are what we typically refer to as the wisdom teeth. The molars and premolars are more for grinding and crushing of food, whereas the incisors and canines are more for tearing, and biting into food. Moving on to the tongue, the other structure that is important in the oral cavity. The tongue is made of skeletal muscle. It is found in the floor of the oral cavity. It's going to be anchored, as we discussed earlier, to the floor by the lingual frenulum. The bottom of the tongue, we can see there are lots of blood vessels. There are the lingual glands, the sublingual glands that we describe, as well as the arteries, veins, and nerves that will supply the tongue. The dorsal surface of the tongue, there are these papilla, and the papilla are these bumpy or raised projections on the tongue that have taste buds. And so the tongue is going to be extremely important in our gustatory perception or taste perception by way of the taste buds and taste pores that are on the tongue. All right, now as we wrap up the oral cavity, the bony structures and connective tissue structures that we want to watch out for are the palate. So the palate has two parts. It has a hard part, which is made of bone, which is the anteriormost portion. All right, so the anterior 2/3 or so of the palate is bony or hard palate. And then the rest of the palate, this posterior portion, is what we call the soft palate. This leads all the way into the uvula. So the uvula is that gangly connective tissue projection that is really obvious when someone opens their mouth very widely. We can certainly appreciate that. And that is mainly the distal projection of the soft palate. Lastly is the palatoglossal arch. So the palatoglossal arch is another landmark that's easily visible looking into the oral cavity. And it really is kind of this archway. It's this bilateral archway that begins to divide the oral cavity from the oropharynx, which is the posterior aspect behind here. So these connective tissue or fibrous archways are really being produced by certain muscles that are spanning that region that are underneath the oral mucosa in the oral cavity. All right, moving on to the pharynx itself. The pharynx in layman terms is typically referred to as the throat. It is the combined region that's posterior to the nasal cavity and posterior to the oral cavity, but also the region where we have the inlet into the larynx and esophagus. So we can divide the pharynx into three smaller divisions. The nasopharynx, which is from the end of the nasal septum to the choana. So here's the nasopharynx, the shaded region in blue. Really the posterior aspect of the nasal cavity. Then we have the oropharynx, which is the posterior aspect of the oral cavity. This goes from the uvula, which is that ending of the soft palate, all the way down to the epiglottis, which is the flap-like covering of the esophagus. Okay, so here is our nasopharynx and then oropharynx. Lastly is the laryngopharynx, also referred to as the hypopharynx. This is from the epiglottis down to the cricoid cartilage, and this is a shared opening where there's entrance into the larynx or leading to the trachea, as well as entrance into the esophagus or leading into the stomach. So this is where we can have choking. This is a really important clinical importance of the laryngopharynx, is understanding the implication for choking. When there's air being moved into the larynx, the epiglottis is open. Here's the epiglottis, and we'll talk about it some more coming up. And if the epiglottis is open, the direction of movement is down into the larynx. So this is why it's important not to chew or speak while you are, laughing or talking or breathing, because there's a mixed communication in terms of the direction of flow. Now, when you are eating and you're swallowing a bolus of food, that should take the path of going into the esophagus, and the epiglottis will help to cover up the laryngeal inlet. So again, really important to make sure that you're not confusing the larynx by having both of these actions happening at once. All right, let's look at some other structures that are found in the nasopharynx. So we have the tonsil groups as well as the pharyngotympanic tube. Now, if we think about the tonsillar groups, they're basically aggregates of lymphatic tissue, and they play a role in the immune system, basically monitoring the oral cavity for any pathogens, bacteria, microbes that may be entering that we may be exposed to from the external environment. So the groups of tonsils are the pharyngeal tonsils, also referred to as the adenoids. And the pharyngeal tonsils are going to be right around the pharyngeal orifice, which is the opening of the pharyngotympanic tube. And if you remember this from last week, this is a connection to the middle ear. All right. The pharyngotympanic tube, it's also referred to as the eustachian tube. It's basically connecting the pharynx to the middle ear. So this is where we can equalize that pressure as we described last week. And so right around that opening is where we have the pharyngeal tonsils. Then we have the tubal tonsils. The tubal tonsils are also going to be in that region, right? So it's going to be more along the mucosal wall of the pharynx. So the pharyngeal tonsils are going to be more in the upper wall, right, where we have the ending of the nasopharynx, whereas the tubal tonsils are actually in the mucosal wall of the opening. Followed by the lingual tonsils. These are at the base of the tongue, as you can see here. These are much harder to appreciate just looking into the oral cavity because they are buried beneath the tongue. And then lastly, we have the palatine tonsils. The palatine tonsils are going to be on either side of the palate, and they are basically not shown in this view, but they're on either side of the uvula here, in the wall of the oral mucosa. Okay, great question here. Do we need to be able to identify all of the tonsils or the palatine tonsils or all of them with the exception of the lingual? I think it's fair to be able to identify all 4 of the tonsils, right? So here are the pharyngeals, here are the tubal tonsils, right, in the wall of the mucosa. Here are the lingual tonsils. And then I'll try to find a different view so that we can appreciate the palatine tonsils as they're in the lateral walls of the palate. Okay. So if we continue on looking at the larynx, so the larynx we described as being the opening into the trachea. Here is the larynx, this inlet portion. It's covered by the esophagus here, excuse me, the epiglottis, I apologize. It's covered by the epiglottis, this flap-like projection that will help to protect that inlet and allow food to slide over the back of that structure. The larynx is going to have a lot of functions, including air conduction to the trachea, diversion of food into the esophagus, and then also the vibration of air moving through these inlet, the folds, will result in speaking and sound. The larynx also has cartilaginous structures associated, so the epiglottis, which is partially formed by cartilage, the thyroid cartilage, which is the superior part of the larynx, and then the cricoid cartilage, which is a inferior cartilage portion of the larynx as well. And just to look at what those look like without the mucosa, here's our thyroid cartilage. All right, here we go. Here's our thyroid cartilage above. Here's our cricoid cartilage below. And then here's the rest of that structure, which is the trachea. Now, above the thyroid cartilage, we have the hyoid bone. So the hyoid bone is going to become important when we talk about some of the strap muscles that are connected later on. So if you look more closely at the larynx, there are 2 folds. There are the vestibular folds, which are more lateral and superior. These do not actually contribute to speech. So they're not going to be referred to as vocal folds because they don't actually help with phonation or speech. These are sometimes called the false folds for that reason. The vocal folds or the true folds are going to be inferior and slightly more medial. So they're kind of closer to the center, and they actually help with the production of speech and voice. And so these will be referred to as the true folds. All right, another extremely important structure that is found in the neck around the trachea. This is the thyroid gland, right? So the thyroid gland is this butterfly-shaped gland. It runs across the anterior aspect of the cartilage of the trachea, specifically the 2nd to 4th cartilage rings, and it is beneath the larynx. It's going to be beneath the thyroid cartilage and beneath the cricoid cartilage as well. The thyroid gland is one of our endocrine glands. It's going to have the thyroid follicles, the parafollicular cells. It's going to be responsible for secreting thyroid hormone, as well as your calcitonin. And so in the endocrine part of our class last semester, we talked a lot about the role of the thyroid gland in the endocrine system. Now, the gland has 2 poles on each lobe. So there's a superior and inferior pole for each lobe. And then there's typically an isthmus. The isthmus of the thyroid gland is that piece that runs across the center of the trachea. So the isthmus is this central portion here. And the isthmus sometimes has an upward projection that's called a pyramidal lobe as well. Now, this is not always present, but if it is referred to as the pyramidal lobe. All right, moving down into the trachea. So the trachea is a long, flexible tube. The anterior part of the trachea is formed by these cartilaginous wings or these tracheal cartilages. And then the posterior portion is really only connected by smooth muscle called the trachealis muscle. And so the rings that form the trachea itself are what we describe as C-shaped rings. They're not completely O-shaped, they're not completely round, but there is a portion at the back of the trachea where the cartilage is interrupted. And the reason for that is to allow for the esophagus, which is right behind the trachea, to be able to expand. So if the cartilage was continuous at the posterior part of the trachea, then that would sort of compress the esophagus as food moves through that muscular tube. And so to prevent that, only the anterior portion of the trachea is cartilage. And the cartilage will eventually end by bifurcating or dividing into two main bronchi, the left main bronchus, which is a little bit more horizontal in its orientation, and then the right main bronchus is more vertical in its orientation. And so one of the important clinical connections here is that if a toddler aspirates a foreign object, let's say the typical scenario that we see is that a child is playing with a toy or a peanut or something, and that gets aspirated into the larynx, it's usually going to end up in the right lung. And that is because of the more vertical and shorter orientation of the right main bronchus. All right, let's speak about the esophagus. So we know the esophagus is posterior to the trachea. The trachea ends by bifurcating at about T4 or so, but the esophagus goes all the way down posteriorly to become the stomach, right? To open into the stomach. The esophagus is going to be one of the three structures that pierces the diaphragm. And as we get down into the thorax, we'll speak more about this, but the esophagus pierces the diaphragm. The aorta also pierces the diaphragm. Here's the aorta, the descending aorta. And then the inferior vena cava is going to be the third structure that has to pierce the diaphragm to enter the abdomen. All right, so let's shift our gears here and begin to look at the lungs themselves. So the lungs are the main respiratory organs. And this is really the ending of that bronchial tree. So we've described the bronchial tree from the nasal cavity into the pharynx, into the larynx. We've talked about the trachea. And so now we get to the visceral organs, which are going to be involved in that gas exchange. The lungs are covered by what's called a pleural cavity. And a pleural cavity is really a double layered membrane that is connected to the lungs internally and is connected to the thoracic cavity externally. So it's a continuous layer that has two sides to it. The visceral pleura is the portion covering the lungs. It's tightly adhered to the outer surface of the lung. And then the parietal pleura is tightly adhered to the surface of the costal part of the thoracic cavity. And so what this creates is sort of a suction mechanism where the movement of the thoracic cavity helps with the expansion of the lungs themselves. And so it's really important that although there is a layer inside or in between these two structures of the pleural cavity, this should be a potential space. There shouldn't actually be any air in this space, in this pleural cavity, and only a small amount of thin serous fluid is within this space to help with lubrication of the two layers, okay? Now, if we do have air entering this space, that can become problematic. That can lead to a separation of these two layers and a collapsing of the lung. So it's extremely important to have the layer, maintained and prevent from interrupting that layer or introducing air into the pleural cavity, because that can compromise respiration. Moving on to the lungs themselves, the outer part of the lung is referred to as the costal surface here. This is the part that's in contact with the ribs and the sternum. The mediastinal surface is the medial portion, which is in contact with the vessels and the bronchi, right? The pulmonary arteries, veins, and the bronchus. And then the diaphragmatic surface is beneath. It's going to be the inferior aspect that rests on the diaphragm. The apex is going to be the opposite end, or the superior pole of the lung that projects up into the the upper thoracic cavity, right? So the apex, the mediastinal surface, which is the medial portion, or the innermost portion, the heart also sits in this space, the diaphragmatic surface being the inferior portion, and then the costal or outer surface being adhered to the thoracic cavity. Okay, now here's the right lung, and we'll talk about some of the features that are unique to the right lung. But I also want you to begin to get an appreciation of identifying the lungs and just being able to determine what side that lung is on, right? You should be able to look at this lung, and without any markings, you should identify this as the right lung. The ways that we can do that is that it has 3 lobes. So that's the most obvious part, right? It has an upper lobe, superior lobe. It is divided from the middle lobe by the horizontal fissure. And then the middle lobe is separated from the inferior lobe by the oblique fissure. So it has 3 lobes and 2 fissures, and it is also bigger and heavier in terms of its overall size and shape. Moving on to the left lung. So again, just being able to look at this without any markings, I can tell that there's only 1 fissure, and so there's only 2 lobes, and so this is definitely the left lung. So it has a superior lobe and an inferior lobe, and those are separated by the oblique fissure. So there is no horizontal fissure on the left lung, whereas both lungs have an oblique fissure, and then the right lung also has a horizontal fissure, all right? The other important features that separate the left lung are the linguala. So the linguala is like this tongue-like projection. That's where the term linguala comes from, but it's really an outer sort of flap-like projection of the left lung, and it is thought to be the remnant of what used to be the middle lobe. Right? So embryologically, excuse me, the middle lobe regressed and did not completely form. And so what is left of that structure is just this flap-like lingual lung.